Good afternoon, everyone. Welcome to this webinar entitled Cardiac Imaging in Early Gestation from Basic to Advanced, presented by Dr. Elena Sinkovskaya. The AIUM is accredited by the ACC-ME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to discuss current guidelines and sonographic techniques for first trimester screening evaluation of the fetal heart, recognize sonographic features of the 4-chamber and 3-vessel trachea views in normal and abnormal hearts at early gestation, incorporate assessment of these views into the first trimester anatomy scan, cite indications for detailed cardiac evaluation in early gestation, and describe the utility of new technologies for comprehensive cardiac evaluation in early gestation. As an ACC-ME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Elena Sinkovskaya consults for GE Healthcare and has a research grant from NIH. Darcy Bleeda-Luna has no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now, I'm pleased to present Dr. Elena Sinkovskaya.
Okay. Hello, everybody. And in the next 60 minutes, we will review the principle of the early cardiac imaging and the existing techniques for early cardiac evaluation. And here is my disclosures that Darcy mentioned before. And approach to the early cardiac imaging can be pretty much the same like we have for the imaging of the heart in the second trimester, and can be divided into 2 big groups. First, this is the screening examination and the fetal echocardiogram. And it's very important to understand the difference between this type of the examination. So screening examination, by definition of screening exam performed on everybody, usually we use transabdominal ultrasound, and we look at the direct and very often indirect markers. So the trainees, people who perform this type of the exam, supposed to have a basic training and be certified ideally by national program as NTQR or international as FMF. So usually the screening examinations in early gestation performed in the OB or MFM offices, and our targeted gestational age is between 11 and 0 and 13 weeks gestation. And the modality that we usually use in performing this cardiac evaluation so early is the 2D and the Doppler if it's needed. Sometimes if this is a difficult patient, we can use Doppler. So also we need to make sure that the use of Doppler is consistent and in accordance to the existing guidelines and safety considerations. Fetal echocardiogram from another side, this is the very specialized exam which is performed by indications. Usually we use transabdominal and utilize the transvaginal ultrasound. We perform assessment of the heart using multiple planes. Usually extra training and expertise in the congenital heart anomalies is required, and perform this exam usually in settings of the pediatric cardiology practice. Based on our experience and what practically we can do, this type of the exams performed between 14 and 16 weeks gestation, and also at that gestational age, as we can see later, we can achieve the best clinical significance of this test. And here we can use all possible modalities that are available on the ultrasound machine for detailed assessment of the cardiac anatomy, function, and blood flow. And here we use 2D, Doppler, STIC, everything that is available for you on your machine. And we start from the screening cardiac evaluation. And here you're probably very well familiar with this image. So the era of early evaluation of the heart and the cardiac evaluation in early gestation started from the introduction of the nuchal translucency measurement to the clinical practice for screening in early gestation for Down syndrome and other aneuploidies as a part of the first trimester screening. And here you can see the image that we usually obtain for NT measurements in the criteria that we need to follow, so that image would be appropriate for interpretation. And it was also very well described and shown in the literature that there is a significant correlation between the nuchal translucency measurements and the incidence of the congenital heart anomalies. And as you can see, even in babies with normal karyotype, with nuchal translucency measurement reaching over 95th or 99th percentile, or the actual measurement over 3.5, you can see that the incidence of the congenital heart anomalies increases exponentially. So this is the first marker that was described for the cardiac screening in early gestation, and for a while this marker was the only one. Later on, we also got the other marker, and here we have the technique how we can assess the ductus venosus. As you know, that the ductus venosus assessment and evaluation of the blood flow also can be utilized for screening for the chromosomal anomalies. And in normal condition, the ductus venosus blood flow has 3 waves. This is the S wave during the systole, D wave during the early diastole, and the A. And as you can see here, in normal fetus, the blood flow through the ductus venosus flows towards the heart during the entire cardiac cycle. If we have no flow during the atrial contraction, or we have even reversed flow, so this could be a marker of the presence of the congenital heart anomalies, and also this is the independent marker that predicts cardiac malformations. And finally, this is more direct marker that was proposed. This is the technique allowing us to take a look at the heart itself and evaluate the tricuspid valve, which is shown here, for presence of the tricuspid insufficiency. And it's not enough to just visualize tricuspid insufficiency in color Doppler. You also need to confirm the presence of this leaking at the valve using the spectral Doppler technique. So as soon as this is the extensive use of the Doppler in the first trimester, some institutions were very concerned about very widespread of this technique for screening, and usually it's used then the nuchal translucency looks abnormal as an additional marker. Also, the next step that was taken in the developing like more individualized system of screening for congenital heart anomalies, then we can put all those markers together and evaluate them simultaneously to estimate the individual risk. And as you can see here, that the performance of nuchal translucency alone for the detection of the congenital heart anomalies in fetuses with normal karyotype not higher than 20%. But if we add nuchal translucency and we add Doppler assessment across the ductus venosus and across the tricuspid valve, we can achieve the detection rate of major congenital heart anomalies up to 50%, with relatively low false positive results rate, and that was very promising. So, and this is the situation, and this is a strategy how we were supposed to screen for congenital heart anomalies in early gestation, probably until 5 years ago. And why? Because back in 2013, the Society of Ultrasound, International Society of Ultrasound in Obstetrics and Gynecology published a guideline suggesting how the first trimester ultrasound should be performed. And a very important part of that guidelines that it's recommended to obtain the four-chamber view, the cross-section of the fetal chest at the level of the four-chamber view, in order to document the normal position of the heart, pointing to the left part of the chest, to document normal heart rate within normal range, as well as, even though this is the optional thing, but as well as to look at the four chambers of the heart itself and see if there is the proportion between those, or we suspect any abnormalities. So that was a very significant step forward, because looking at the heart itself in the first trimester, it's definitely more beneficial than looking at the indirect markers such as the nuchal translucency or ductus venosus alone. And here you can see the technique for early anatomical evaluation that we're using in our institution. We always start from the mid-sagittal view of the fetus, where we can measure the crown rump length, where we can magnify this part of the fetus and assess the nuchal translucency, nasal bone, posterior fossa structures, and then we turn the probe 90 degrees, and here we can assess the axial planes, including the head, chest, abdomen, and pelvis. And of course, the transverse view number 2, this is the main focus of today's talk today. So what we can see at the transverse view of the chest. So here we have two symmetrical ribs on each side of the chest. We have the spine here, and this is the heart. So we clearly can see the four chambers in the heart. And here we can assess the following parameters that we are going to talk about in a few minutes. So this is the cardiac axis, cardiac proportion, cardiac size, position of the heart, and the heart rate. And as you can see on this image, it's pretty straightforward and pretty easy to assess. Not to forget that in the chest, we also have other organs. So we also can look at the lungs parenchyma and at the presence of the pleural or pericardial effusion. So this is a lot of information that we can get from this view in the early gestation, and thanks to the very significant improvement in the image quality of the existing machines, we can see very significant improvement in resolution and a magnification of the image that allows us to see all those details. So four-chamber view traditionally used for screening in the second trimester for congenital heart anomalies. And one of the parameters that we can measure at this plane is the cardiac axis. And also this parameter can be evaluated in the first trimester. So here it is a technique how the cardiac axis can be measured in the first trimester. We need to obtain the four-chamber view, make sure that you have the complete rib on each side of the chest. That also allows you confirm that this is the very good axial view of the chest. Magnify your image so that the area of interest, the fetal heart, would occupy the most of your image. And then you apply two measurements. So one line, this is a line that dissects the chest in the anterior-posterior direction and divides it into two equal halves. And the second line traces the interventricular septum. Angle between these two lines, as shown here, is the cardiac axis. If you can't see very well, which is not that unusual in the first trimester, you can use color or power Doppler very quickly just to help you to navigate where the interventricular septum is and is the placement of the second line. And here you can see how the technique works. And again, this is demonstrated the normal cardiac access in the first trimester. To confirm the clinical significance of the measurement of the cardiac access, we undertaken the study that was performed back in 2015 and published in the Journal of Obstetrics and Gynecology. So in here you can see that we detected 197 cases of congenital heart anomalies, and we matched every case with 2 normal controls. And here you can see the distribution of our population. About the half had abnormal cardiotype, 78 had normal cardiotype, and about 58 cases we had major congenital heart anomalies with normal cardiotype and without any concomitant extracardiac malformations. First, in the study, we decided to check and demonstrate how behaves the cardiac access between 11 and 15 weeks gestation in the normal group and control group. And here you can see that the cardiac access establishes this position in about 12 weeks gestation, then the crown ramp length reaches about 50 millimeters, and then it stays unchanged by the second trimester, and pretty much the average cardiac access after 12 weeks is about the same. It's 44% plus minus 20. And here you can see that the range that we obtained in our study was very similar to the range that we are using in the second trimester. But then we plotted all the abnormal cases against the normal controls. You can see that only 26% of fetuses with congenital heart anomalies had the normal measurement of the cardiac access in the first trimester. And we were able to detect that 2/3 of our cases had abnormal cardiac access. And abnormality of the cardiac access, we were able to divide into 3 different groups. The most common situation, this is a deviation of the cardiac access to the left, and this was observed in a half of our abnormal cases. And about 10% we had the right deviation of the cardiac access, and then we had the situation then we were not able to obtain the access because the interventricular septum was not visualized. And this is very important group, as we can see later. So here we have an example, abnormal deviation of the cardiac access to the left, cardiac access measured 70 degrees, deviation to the right, cardiac access measured 11 degrees, and here we have pretty much just 2 chambers in the heart visible. This is very obvious that this is abnormal appearance of the 4-chamber view, and here we were not able to measure the access. So the mechanisms of the abnormal cardiac access really unknown. Several theories were proposed that you can see here, that for some anomalies such as conotruncal anomalies, the abnormal cardiac access results from abnormal rotation of the bulboventricular loop in early embryogenesis. And this is what we can usually see in fetuses, the hydrology of a lower common arterial trunk and other conotruncal anomalies. Then the size disproportion of the cardiac chambers, which may occur in the cardiac anomalies such as the hypoplastic left heart syndrome or pulmonary atresia with intact interventricular septum. In this situation, we have abnormal development of the heart due to the hemodynamical issues, and as the abnormal blood flow result to the abnormal growth of the chambers, and we can see the discrepancy in chambers that also will result to the abnormal cardiac access. And finally, abnormal cardiac access can be observed in fetuses with abdominal wall defects, such as the gastroschisis or omphalocele, and here the cause of that believed to be abnormal pressure caused by abnormal development of the abdominal wall and diaphragm. So how performs the cardiac access comparing to the enlarged nuchal translucency? So here you can see how the comparison between the nuchal translucency abnormal cardiac access in our group, where we had again 197 patients. So you can see that then we put fetuses with normal and abnormal cardiotypes. So the significant difference we can see here in the univentricular heart. So in the hearts, then we have just one functional ventricle. But if we eliminate all the fetuses of abnormal karyotype, so we can see that the nuchal translucency performance is not that impressive, and that the abnormal cardiac axis allows us, for example, to detect 100% of univentricular hearts. This is very clinically significant group, and allows us to see and detect 76% of conotruncal anomalies, where ENT performs really bad and allows us to detect just 10%. So looking at the heart itself is actually very beneficial and allows us to improve our detection rate. What we can see and what we learned from the cardiac axis study, and this is what we are doing on every single patient now in our clinic, then we perform scan between 11 and 14 weeks gestation, that by taking the measurement of the cardiac axis, we can also look at the proportion of the cardiac chambers. And this is a good example showing that the right side of the heart looks bigger than the left side of the heart, and that the cardiac axis here is definitely abnormal. And the reason why it's abnormal, most likely this is discrepancy. So here there are the two examples. Here we have the patient with the later diagnosis of the aortic coarctation. It was suspected at 13 weeks and then confirmed later. And you can see that the left side of the heart is significantly smaller than the right, even though the cardiac axis was normal in this case. And here we have the opposite situation. We have the right side of the heart is significantly smaller than the left, and here we have the right deviation of the cardiac axis. So the discrepancy of the 4-chamber view, which is noted as early as 13 weeks, it's a very important thing, because usually over time this discrepancy becomes more significant and more significant clinical implication for the fetus. But the very small but relatively important group, this is the group of the anomalies, the single inflow. This is a situation that we can't identify the interventricular septum, and this is a situation where the cardiac axis cannot be measured. If we look at this case very carefully, we can see right atrium, left atrium, and then we have just one single ventricle here. And in this case, this is just large intracardiac echogenic focus. This is just the subvalvular structures of this valve, which are very echogenic. And this is a situation of the tricuspid atresia. We have a teeny tiny rudimentary right ventricle on the side, which is without the specific knowledge and, very careful look, probably it's impossible to recognize. So that the situation, then you can't measure the cardiac axis clinically is very significant. And if you suspect that you may deal with the univentricular heart, as you know that the complete repair for those cases is not really possible. So this is the situation that needs to be handled very early, and probably consult the specialists for the appropriate decision making from the family. This is another example. Then we use color Doppler, and we can see that here it seems that there is 4 chambers in the heart. Obviously, this side of the heart looks much smaller, but color allows us to see just one inflow. Again, this is a single inflow situation. And this is clinically very significant problem that after birth will require multiple stage repair, and all of those repairs going to be just palliative surgeries. So what else we can recognize looking at the 4-chamber view? We can recognize how big the heart is in comparison to the size of the chest, and how to look at this and just think about how many hearts of this size you can fit in this chest. Ideally, heart's supposed to take about 1/3 of the area of the chest, and 3 hearts of this size should be possible to fit into this chest. And it's pretty obvious that it's not that easy. So this heart is enlarged, And we can see here that the largest part of this heart is the right atrium. And even without applying color Doppler, most of the time the reason for that is the presence of the tricuspid insufficiency. And this is this situation. It's a different fetus where we have significant insufficiency on the color Doppler and holosystolic tricuspid regurgitation confirmed by the spectral Doppler. And usually the very significant cardiomegaly, the significant tricuspid regurgitation seen in early gestation has a very poor prognostic outcome. But situation is not that clear all the time. So if you look at this heart, so can we see any problems? You may say, okay, maybe this is a little bit of the pericardial effusion, but this is a transvaginal approach. And here, usually in early gestation, you can see some fluid in the pericardium. This is normal. This is nothing to worry about. But then we put color on. And what we can see here, we can see that this is the mitral valve, and we have significant mitral regurgitation. We have a little bit of the tricuspid regurgitation. This is a confirmation by spectral Doppler. So this regurgitation is real. And what this patient was diagnosed later in pregnancy, it's very clear that this is common AV canal. And here we have common valve, septum primum ESD, and inlet VSD. So that was a pretty major congenital heart anomaly that in the first trimester presented with very subtle changes, and only placement of color and use of color helped us to suspect that there is something abnormal. So the key here that the presence of a tricuspid insufficiency can be a very important thing for the prognosis and the diagnosis of the congenital heart anomalies. And even more important to see if you see the mitral regurgitation, because presence of the mitral regurgitation pretty much always is a marker of the major congenital heart anomaly. So sometimes you can see regurgitation not on the left side, not on the right side, but kind of in the middle of the valve and AV valve area. And this is also very important marker. If you see that right at the basis of the heart, where the crux of the heart is, so that means that most likely you are dealing with the common AV valve. And common AV valve tends to leak right in the middle. So that also will be very helpful in your early detection of the cardiac anomalies. So what's wrong with this heart? So what we can see here, large cystic structure, and the heart is pushed to the other side of the chest. And it's very rare situation, but this is the actually normal heart affected by the extracardiac anomaly, which is the diaphragmatic hernia, with the bowel and stomach up and visualized in the chest that early. So obviously a very poor outcome is expected in this situation, but not always the diaphragmatic hernia presents in early gestation and this dramatically. So here we have the scan at 13 weeks gestation, where if you don't look carefully at the position of the heart, you're probably not going to call this heart abnormal. But if we imagine the line that dissects the chest in the anterior-posterior direction, you can see that the heart sits right in the middle. So this is somehow the mesocardium. And that was the only clue. We followed this patient along, and later in the pregnancy, we were able to see all the classic presentation of the left-sided diaphragmatic hernia, the portion of the stomach and liver up. And so also looking at the position of the heart, that could be a clue as early as 13 weeks gestation for the extracardiac anomalies that may have significant impact on the well-being of the child after birth. So what's wrong here? So again, here we have the stomach and the chest, we have liver in the chest, and we have the heart displaced completely in the right side of the chest. So this is obviously a very large left-sided diaphragmatic hernia. But if we look at the heart itself, we can see that there is very abnormal heart and very abnormal four-chamber view. We have the right atrium, left atrium, we have one ventricle and one single EV valve. And if you look very carefully, we can see that this is a tricuspid atresia, this is the VSD, and very small rudimentary right ventricle. So this is a clinically very difficult situation, as we have the significant abnormality of the diaphragm that would result to the hypoplasia of the lungs, and we have very severe cardiac malformation. So all this, by looking at the four-chamber view and by looking at this slice of the chest in early gestation, can be suspected. And again, the presence of just single inlet can be confirmed by color Doppler here. So let's take a look at those clips. What's wrong here? So here we are looking at the size of the heart. It's definitely enlarged. We have the tricuspid insufficiency maybe, but maybe just insufficiency in the middle here. That means that most likely we deal with the common valve. But what also is striking about this situation, that the heart rate is abnormal. So it seems to be very slow. And it's not just a problem that the clip playing, so this is the true abnormality of the heart rate. And then you see something like this. It's very important to detect and measure the heart rate at atrial and the ventricular level, because it could be quite different and very confusing for clinicians. And here we did this technique. So we applied the M mode cursor across the ventricles and across the atria, and we got the normal rate of the atria, about 144, and very slow ventricular rate, which is 69, 70, and that was consistent with complete heart block, which at 13, 14 weeks of pregnancy has a very poor prognostic indication. But the patient decided to continue the pregnancy, and this is the same fetus, 22 weeks gestation. You can see that the heart rate is even slower, but all the appearance that we had in early gestation is actually clearly seen here. We have common AV valve, common ventricle, and common atrium. Baby is already getting hydropic, and you can see that the heart rate dropped down to 31 beats per minute. So this is very tragic situation, and it resulted in the demise in a couple of weeks after this scan was done. As soon as we are encouraged by the current guidelines to look not just at the cardiac anatomy, but try to evaluate major anatomical structures of the fetus as early as 11 and 14 weeks gestation, so we can evaluate the visceral situs. And here you have the example how that can be done. So we have a clip as presented here, or just static pictures as labeling of the left and right side of the fetus, and we're supposed to identify the stomach on the left side and the apex of the heart pointing to the left side. So what if we look at this situation, what we can see here in this clip, that the apex of the heart and the stomach are actually on the opposite direction. And here we have the static pictures retrieved from this clip showing that indeed stomach is on the right side. We have a normal appearance of the portal sinus, inferior vena cava, and the aorta, but the apex of the heart is still pointing to the left. So this is the situation of abnormal visceral situs, situs inversus with levocardia, suspected at 12 weeks and 6 days, and using transvaginal ultrasound, and was confirmed later. So here is another example. We can see stomach is on the right side. We can see abnormal appearance of the portal vein system here, but what also is remarkable that we can't recognize any evidence of the inferior vena cava at that level. Instead, we have the other vessel that runs in parallel to the descending abdominal aorta, and this vessel is dilated azygous vein. The same vessel is visualized behind the common atrium in the chest, and this is consistent with the interrupted IVC or genesis of the hepatic segment of the inferior vena cava with the vein azygous continuation. And together with this complex heart anomaly that we can see here, an abnormal heart rate, so that makes this case very suggestive for situs abnormalities such as the left isomerism. So here is the end of our overview, how helpful the 4-chamber view can be in the first trimester screening for congenital heart anomalies. And I think that our European colleagues went even far, and they suggesting that in the first trimester, you can also obtain the images of the outflow tracts to improve your screening. And also, as we've seen before, the use of color Doppler is very beneficial. And suggested protocol is to look at the 4-chamber view, 3-vessel view in 2D and using color, and that can optimize and pretty much maximize your ability to detect major congenital heart anomalies in the first trimester. So how that strategy for screening would look for us. So here you can see the two views retrieved from the same fetus during the first trimester examination. Here we have the 4-chamber view, the views of color, and here we have the 3-vessel and trachea view. I believe that many of you are very much familiar with this view for screening used in the second trimester, because this concept was introduced more than 20 years ago to the clinical practice. But just as a reminder, we have the 3 vessels visualized here, this being the pulmonary artery, this one is the aorta, and here superior vena cava. Both arches supposed to be running on the left side from the trachea. And the color Doppler is supposed to show the same direction of the blood flow. We need to visualize pretty much similar size of those vessels in this view. PA needs to be a little bit more anterior in comparison to the other vessels, and the order of the vessels from left to the right supposed to be pulmonary artery, aorta, and superior vena cava. So pretty much the same protocol for assessment of the 3-vessel and trachea view in the first trimester as in the second. So how that approach can be used for diagnosis of congenital heart anomalies. Here you have one clip showing the sweep from 4-chamber view to the upper mediastinum, demonstrating the 4-chamber view and then the 3-vessel and trachea view. And here we retrieve those planes from this clip, and you can see, if you look here, that the cardiac axis is significantly deviated to the left, and that the 3-vessel and trachea view demonstrates just one big vessel, and we can see the normal appearance here. So this is what's enough to suspect a major congenital heart anomaly, and this is what would be typical for tetralogy or follow the significant obstruction of the right ventricle outflow tract. So, but what's wrong here? So here we have the 4-chamber view, and here we have a sweep of the 3-vessel and trachea view. So you can speculate that there is a small VSD here, even though be careful, because this area represents the perimembranous portion of the septum, and here we can have the dropout artifact. In particular, in the first trimester, this area looks very thin, so that may result in false positive results of the interventricular septal defect. So again, the goal of the ultrasound at this time, as early as 13 weeks gestation, to rule out the major anomaly. And major anomaly cannot be recognized here in the 4-chamber view. The major anomaly that we can recognize is demonstrated here in the 3-vessel trachea view. So indeed, on this sweep, through entire sweep up and down, we can see vessels merging together. So we can see any difference, any appearance of the pulmonary artery, aorta, and superior vena cava. We can see the vessel here that seem to be bifurcating, and then we have the vessel that goes straight, and we have the superior vena cava on top. And this is what's typical for transposition of the great arteries. So then the vessels are located one and beneath the other, and moving up and down in the chest, we can't align them as the V connection or visualizing how they're converging. We actually see one of them in one time, and this specific appearance of the three vessel and trachea view demonstrating just two vessels, that would be aorta here and superior vena cava here, is very typical for transposition of the great vessels. Okay, and that was the diagnosis suspected at 13 weeks gestation and confirmed later. So why the three vessel and trachea view is important? Most of the time, it allows us to confirm suspected anomalies of canotruncus at the four-chamber view. As we said, usually those anomalies present the deviated cardiac axis. And also, this is a very important view for detection of different anomalies of the aortic arch. So, but most of the time in the first trimester, we can see just two vessels at the level of the three vessel and trachea view. And here is the example of the severe CARC patient. Then we have superior vena cava, we have pulmonary artery, and no evidence of the aorta. And here we have significant obstruction of the right ventricular outflow tract, the pulmonary atresia and interventricular septal defect, where we have the superior vena cava and the other superior vena cava, so the two superior vena cavas, and we have just large vessel that represents aorta and no evidence of the pulmonary artery, at least in the 2D imaging. So the appearance of the three vessel and trachea view like this should always require the further evaluation that the cardiac anomaly should be immediately suspected. So, but let's take a look at this case. So we have pretty normal four-chamber view, and here we have the three vessel and trachea view. So take a look at this for a while and see if you can recognize any problems. Okay. So, and indeed, if you look very carefully at the three vessel and trachea view, we can see that this is the pulmonary artery, this is the aorta, and this is superior vena cava, and that the trachea is actually located in between the ductal arch and the aortic arch. And this is how the right-sided aortic arch can be suspected as early as 13 weeks gestation. And here we have that U sign traced here for you so that you can compare this moving image that the aorta and the pulmonary artery are actually running on each side of the trachea, not on the left from it. And finally, if you use color, if you're very familiar with color Doppler, so three vessel and trachea view allows you to see a distribution of the head and neck vessels. And here is the very nice example of the aberrant right subclavian artery. As you know, that aberrant subclavian artery is the soft marker for Down syndrome. The same like echogenic intracardiac focus and pylectasis. So this is very common findings in babies with Down syndrome and occur in about 21% of all babies with trisomy 21, but also can be found in other anomalies and chromosomal anomalies. So in this particular fetus, we had DeGeorge syndrome, that's the absent thymus, and that was the only cardiac abnormality that was detected that early and later in this pregnancy. So also it's important to emphasize the role of the color Doppler. And here we have the example, then you can see that this is the four-chamber view that seems pretty much normal. And use of color Doppler allows us to identify the interventricular septal defect very easily, which is relatively large in this case. Occasionally, the muscular VSD also can be visualized as early as 13 weeks gestation, as you can see here, and this is the confirmation later in pregnancy. But of course, this is the incidental finding, and it's not dangerous that and that's not a big deal if you are not going to see it on the first trimester ultrasound. First of all, because this anomaly has no clinical significance for the fetus and for the neonate after birth. So that's why if you miss the small muscular VSD, it shouldn't be that worry about it. But Sometimes you can see it in the first trimester. The other advantage of the use of color, this is the visualization of the pulmonary veins, and this is more important than the visualization of the interventricular septum, because total anomalies pulmonary venous return, this is the anomaly that most of the time missed during the pregnancy, even in the second and third trimester, and even more difficult to suspect in the first trimester. So this is a case that we had several years ago, and here you can see that abnormal appearance of the four-chamber view, but in 2D we also saw some structure that appeared vascular using color Doppler that looked like a tweak sign, and this is typical view for the abnormality of the venous return. So we Dopplered this vessel and we realized that this is really restricted blood flow, and using the sagittal view we confirmed that this is total anomalies pulmonary venous return. There's a drainage of that vertical vein to the portal vein system. So this pregnancy, that diagnosis was made as early as 12 weeks and 6 days. So finalizing discussion on cardiac screening, I spent pretty much most of my time on the screening because this is the most important fetal cardiac imaging, on my opinion. The goal of the screening is to identify pregnancies at the high risk for fetal heart defects. And in this group, in this high-risk group, the fetal echocardiogram can be recommended and performed. And without a really good organized program of cardiac screening, the fetal echocardiography program cannot be possible. So the heart anomalies are never missed in the settings of the pediatric cardiology, or at least not always. But we are not doing very good at the detection of the fetal cardiac anomalies because we are not detecting them in the screening setting. So first trimester screening should help to identify the high-risk group for heart anomalies, and we need to arrange referrals for the fetal echocardiography labs. So in here you can see the indications for the fetal echocardiography. As you can see that this is the study that usually performed based on indications, and here are all of them that we just discussed in details. It's increased nuchal translucency, reverse flow in the ductus venosus, presence of tricuspid or mitral regurgitation, abnormal appearance of the four-chamber view, including cardiac axis, just a suspicion of the major heart anomaly if you do the four-chamber view and the pre-vessel and trachea view, poorly controlled diabetes, the periconceptional hemoglobin A1C over 10, you know that the risk of those fetuses to have structural anomalies is about 40%. Maternal anxiety, this is a situation that the parents had already one affected baby. And finally, the problem that we have increasingly affecting our pregnant population, this is a morbid obesity. So this is the indications that we are using in our lab. There is no specifically designed guidelines that we can use, but I believe at this point there is no standard of care, and each institution has its own indications, and I think that this is the most commonly used in the literature, and this is what we use in our lab. I also want you to remind that the American Society of Echocardiography has the clinical practice parameter on fetal echocardiography, and for the few minutes that we have for fetal echocardiography in early gestation, so I would like to refer to this document so you can review what the echocardiography is in the second trimester. So in the early gestation that we do detailed assessment of the fetal heart, so that usually the combined approach should be used. So we should look at the heart using the transvaginal and transabdominal approach. We look at the certain views, and this is all the views that we are looking at the second trimester, and every attempt should be made to take a look at these 8 views and document them in 2D and using color Doppler. So and here you can see our traditional transverse views. They are very well known. This is the situs assessment. This is a four-chamber view and the pre-vessel and trachea view. We have the outflow tracts, left ventricle outflow tract and right ventricle outflow tract. And then we have the sagittal views showing the ductal arch, bicaval view, and the aortic arch. So how successful visualization can be of each diagnostic plan in the first trimester? You can see here that the best visualization can be achieved for the four-chamber view and the pre-vessel trachea view as early as 11 weeks gestation. That's why probably these two views were selected for the screening as well. And the complete evaluation of the heart and all the views can be obtained in color and in 2D, so is usually achieved in about 75% starting at 14 weeks. So that's why it's usually recommended to perform this ultrasound in about 14 to 15 weeks as the early echocardiogram. But of course, the attempt can be made earlier. And a few slides just to show how the new technologies can be helpful in detailed evaluation of the fetal heart. So here we can see the STIC technology allowing us to see heart in 3D and using color. And here we have our favorite pre-vessel and trachea view, and the resolution is so good that here we even can see the internal thoracic arteries that are running on each side of the thymus, allowing us to confirm that it looks normal on this fetus. Also, we can use the setting to let the system to demonstrate specific part of the heart. And here we are focusing on the interventricular septum, which is very clearly visualized here and appears intact. And of course, this is a very important technique when we suspect the cardiac anomaly. And here we have the case of the common AV valve and common atrium. And so here we have significant tricuspid significant insufficiency on this common valve. So we can assess all the details of this anomaly. And also important thing about the 3D technologies, in particular STIC, that it doesn't really take that much time to learn, and it doesn't take that much time to obtain, but all the information about this heart is actually contained in that 3D volume, and you can send that volume to the specialist for the second opinion. So that's why that's probably very important tool that we can use in addition to our traditional techniques. Here we have the other examples with color and without color. So it's very easy to recognize that the left side of the heart, even at that early stage, is so poorly developed that this is consistent with the classic hypoplastic left heart syndrome. And in my experience, it was also much easier showing these pictures to the parents to explain what's really wrong with the heart. For some reason, patients, they have a better understanding of the pictures like this than just the grayscale pictures, and that could be very helpful for the counseling of the parents, especially about such a severe anomaly as the hypoplastic left heart syndrome. Here is another example. We have a really small right side of the heart here. So we have the right atrium, left ventricle, and teeny tiny VSD, which actually color highlights the almost not existing right ventricle, consistent with the tricuspid atresia. But what other details we can see on the 3D, which actually, frankly, escaped my attention when I was looking just at the 2D pictures. This is abnormal vasculature at the level of the liver, and this big vessel next to the descending thoracic aorta that you can see behind, and this is indeed the dilated azygous vein. And here we can clearly see that on top of the very significant and severe cardiac anomaly, we have the anomaly of the venous system consistent with the interrupted IVCA azygous continuation. So that the ability to take a look at the volume, develop the volume, and get more details about this anomaly, to explain to parents, to have ability to have a second opinion with your colleagues, across the globe. So this is a real advantage of the 3D technology nowadays. So, and we are almost finished. So here I have some conclusions that I believe that we all familiar with. So most of the time, the complex of the cardiac anomalies that we diagnosed early in the pregnancy, they're quite different from those that we see in the second trimester. So this is usually more complex abnormality. They have a high association rate with aneuploidies and also have the high association rate with the cardiac insufficiency and overall fetal hydrops. So I would like to leave you the idea that it's really easy than you think, that technical adjustment of your machine should include the assessment of the heart in early gestation on the NT setting. There's some adjustments similar to the fetal echo, so play the presets on your machine and create some kind of hybrid preset specific for you, so that would be very beneficial and much easier to evaluate the heart in early gestation. Try to look at every single scan that you perform, so that over time you will acquire expertise. Try to incorporate cardiac access or assessment of the four-chamber view in your clinical practice. It's questionable should cardiac access be measured on every patient, but to pay attention to this position is usually very beneficial. Also, try to get familiar with the color Doppler settings and ideally the high definition color Doppler. And of course, look at the 3 vessel and trachea views. So I think that this is the most important points that I would like to leave you today, this lecture. And I would like to thank you very much for your attention, and I will be happy to answer all your questions. Thank you so much.
You've got 2 questions.
Okay.
I don't know. Can you see them on your screen, or would you like me to?
Yep.
Okay.
At what gestational age do you recommend performing the early fetal echo without need to use transvaginal ultrasound? So I realistically 15 weeks gestation, this is probably the time then you won't be able to benefit from the transvaginal scan, because the fetus is usually bigger, especially if baby is in a breech presentation. So you can try, but it's not going to be successful or helpful anyway. So I would say that the transvaginal ultrasound is the most helpful in about 14-15 weeks gestation for detailed assessment. I also use this ultrasound approach earlier, especially if we need to make some diagnosis or decision earlier than 14 weeks and the patient insisted. Also, transvaginal ultrasound for screening if you suspected something on transabdominal. So we always prefer to take a look transvaginally right away, just to make sure that your suspicion makes sense, that to double check your suspicion. So the question number 2, does the direction of the deviation of the cardiac axis, left or right, give us any indication of what the specific cardiac issue might be? Yes and no. So usually if it's the deviation to the left, it's the most typical for conotruncal anomalies such as tetralogy of Fallot complex, such as the classic tetralogy of Fallot, tetralogy of Fallot, the pulmonary atresia, common arterial trunk. Double outlet right ventricle tend to have more right deviation of the cardiac axis. Also, left deviation of the cardiac axis is typical for obstructive lesions of the left heart, such as the hypoplastic left heart syndrome and coarctation. So the deviation to the right also can be seen in obstructive lesions of the right side of the heart, such as the interrupted aortic arch. But cardiac axis itself is like a marker. So then you have the positive screening test. So and presence of the abnormal cardiac axis would be considered the positive screening test. Then you need to run the diagnostic test, which is the fetal echocardiogram, to get more details and to put together the final diagnosis. So that's why I would not, it is typical to have left or right deviation for specific anomalies, but just the deviation of the axis is not going to help you with the final diagnosis, because for the final diagnosis, you need to take a look at different views and see so more details about the heart in general. And usually that requires consult with specialists in the pediatric cardiology. Okay, so the next question, what are the PRF setting do we use for Doppler to visualize four-chamber view, pulmonary veins, and other views? Okay, so about settings. Usually we perform ultrasound assessment of the fetal heart in early gestation in the screening setting using the specific preset that in our practice we use for nuchal translucency. So many manufacturers of the ultrasound machines now have the preset for the evaluation of the pregnancy in first trimester, including the specific presets for assessment of the nuchal translucency. So if you use that preset, so the PRF of pulse repetition frequency is already set up, and you can just a little bit adjust that depending on the specific patient you're scanning at the moment. Usually in the first trimester, I prefer to keep my PRF in about 2.5 or lower if I need to see the pulmonary veins, but you can go up to 3. After that, usually the image is not so sensitive and you don't see that much color to feel all the ventricles. So that is the presets that we are using. So, and usually color Doppler preset, it fits for the four-chamber view and outflow tracks. You will use a little bit higher PRF, about 2.53, and for pulmonary veins visualization, you can go a little bit lower as well for the branches of the aorta, or if you're specifically looking for aberrant right subclavian artery. Okay, so I actually expected that last question. So what is your opinion on bioeffects and using Doppler on the first trimester? Should we only perform on the high-risk patients, the high-risk ratio, the high-risk benefit ratio, and if we can use one, and if we can use on everyone, what should we telling to our patients? I think that this is critical to adhere to the guidelines that AIUM and ESOG published about use of Doppler in the first trimester. And as you know, that we can use it briefly, and we always look at the 2D alone, and if something looks abnormal for us, so then we can use color. And if something abnormal appears on your 2D image, it's already justified that we need to take another look, because it's definitely going to be beneficial for the patient. But again, so that the evaluation with the Doppler should be very short. You need to monitor the thermal and mechanical index, and your machine should be preset to the lowest exposures for the first trimester scan anyway. And use of color is not that high intensity in comparison to the spectral Doppler. So that's why if you're considering to use color Doppler, or use Doppler, you need to use color Doppler first, and spectral Doppler, frankly, we don't use very often. So we confirm the presence of tricuspid insufficiency, and usually it's pretty obvious on the color. And if this is the case, so that could be definitely beneficial to the patient. So, but the key is to adhere to the recommended ALARA principle and recommended levels of the mechanical and the thermal indices. This is very important.
Okay, we're going to have to call it a day now. Thank you so much, Dr. Sinkovskaya, for this wonderful presentation on behalf of the AIUM. Thank you to everyone who participated today. Please remember to complete the post-test and the activity evaluation, and we hope you enjoyed this presentation and will join us again in the future. So long, everyone.